Welcome to the Deep Dive, the place where we take the most critical knowledge stacks, the ones standing between you and professional success, distill them, and give you the high-yield shortcuts you need to be brilliantly informed. Today, we are undertaking a really crucial mission. We're focusing on what is probably the highest yield, most frequently tested, and, let's be honest, often the most stressful area for anyone preparing for the MSRA situational judgment test. And that is clinical communication skills.
The big one.
It really is. We got a whole stack of resources here. We're pulling from textbook chapters, the latest GMC guidelines, especially that updated Good Medical Practice 2024, and just dozens of high-frequency SJT scenario patterns. The focus is squarely on how you manage the human side of medicine, particularly when everything's under pressure.
Which is most of the time.
Exactly. Yeah. So to set the scene, let's just dive straight into one of those pressure cooker moments that this JT just loves to create. Because I think this one scenario, it just sums up everything we need to cover. So imagine this. You are running 20 minutes late in clinic. The patient you finally call in, they're tearful about their ongoing pain, and they're openly saying they're scared they have cancer, even though, no diagnosis has been made.
Right.
And before you can even properly sit down and engage, their relative leans in and really urgently but quietly asks for confidential information about the patient's scan results. They say, "She's too upset to handle this, just tell me."
Wow.
Yeah, that's three conflicting demands hitting you all at once. Time pressure, overwhelming emotional distress, and direct request to breach confidentiality. You have maybe 30 seconds to react. How do you even begin to handle that?
That scenario is it's brutal. It feels impossible, and that's the point. It's precisely what the SJT tests. Your ability to stick to your professional duties when you're under immense stress. The immediate, human instinct is probably to rush, maybe to snap at the relative because they're interrupting, or to just offer some quick reassurance to the patient so you can move on and catch up.
It'll be fine, don't worry, that kind of thing.
Exactly. But as you said, those gut reactions, speed, avoidance, they're the fastest way to a low score. And more importantly, in real life, they lead to unsafe, non-compliant practice. The SJT is scoring your ability to follow a safe structure, not your speed.
And we have to stop calling this stuff soft skills, don't we? I mean, that term just doesn't do it justice.
Oh, absolutely. It's a term I really dislike. We have to be clear that communication skills are not soft skills. They are essential protective equipment. They're patient safety in action. They are your medical legal protection when something goes wrong. They are, the foundation of trust that allows the whole NHS to function. The stress the SJT puts you under is a deliberate simulation because communication is often the very first thing to break down when the pressure is on.
So, okay, let's strip it all back then. For someone listening, revising, trying to get their head around this, what's the one core truth for communication questions in the SJT?
The core truth, the one-sentence takeaway, is that structure, empathy, and safety always beat speed, avoidance, or assumption. Always. If you apply a recognized framework, whether it's for breaking bad news, de-escalation, whatever, you will naturally choose the safer, higher scoring option. You're prioritizing GMC standards and patient well-being over your own personal comfort or, the clinic timings.
Right. And why does this topic get so much airtime? Why is it worth a whole deep dive? It seems to carry this disproportionate weight in the exam and in practice.
It does, and for three really interlocked reasons. First, it is a core GMC duty. The new Good Medical Practice 2024 has whole domains dedicated to patient partnership and communication. This isn't just a nice-to-have, it's foundational professionalism.
It's a must-do.
It's a must-do. Second, clinically, good communication drastically reduces complaints. Most complaints aren't actually about a clinical mistake. They're about someone feeling they weren't listened to. It also improves adherence to treatment, and it's the only way to get truly shared decision-making. You can't get valid consent without it.
And the exam itself?
Well, third, for the exam specifically, the SJT uses communication scenarios with just an incredibly high frequency. It can be, 30 to 40% of the whole paper sometimes. And they're testing your consistency. Can you do the right thing when you're tired, stressed, and running late? The most common trap, as we said, is rushing, interrupting, dismissing emotions. If you do any of those things, if you interrupt a concern, offer false reassurance, fail to use an interpreter, you are compromising patient safety. And the SJT penalizes any compromise to safety and professionalism really, really heavily.
Okay, so let's unpack that. Let's start with the absolute foundation. Before we even get to the high-stakes stuff, the bad news of the angry patients, we have to talk about listening. If the patient isn't heard, nothing else you do really matters, does it?
Nothing.
The fundamental rule, according to all these sources, it feels so counterintuitive for a busy doctor, which is slow down to speed up.
It's so true. Rushing saves you 30 seconds in the moment and costs you 30 minutes later. In callbacks, in re-explaining things, in managing a complaint, active listening is a deliberate skill. It's not just passively hearing words. The textbooks define it as this combination of attention, empathy, reflection, clarification, all to understand what really matters to the patient. If you rush, you miss the hidden agenda, the underlying fear, and that's where things go wrong.
So what are the practical tools then? It's much more than just nodding along, isn't it?
Oh, much more. And this is where it gets high yield for the exam, because there are frameworks that turn the subjective process into objective, measurable steps that the SJT can actually score.
Let's start with the nonverbal stuff, the physical side of it.
Right. You have to be present, stop typing, put your pen down, turn to face the patient, and critically allow for silence. Don't feel you have to fill every second. The framework for this is the solar posture. It's your physical commitment to listening.
Okay, break that down for us. Solar.
So S is for square. You face the patient directly. O is for open, no crossed arms, no defensive body language. L is for lean, just a slight forward tilt to show you're engaged. E is for eye contact, appropriate, not a stare down, but maintaining that connection. And R is for relaxed, maintaining a calm, open presence.
So solar is the signal you send. It says, I am here and I am listening. Then you get into the content, which is where the famous IC model comes in.
And ICE is absolutely crucial because it invites the whole story, not just the symptoms. It uncovers the real agenda.
Ideas, concerns, expectations.
Exactly. I for ideas. What do you think might be causing this? This reveals their health beliefs, their fears. C for concerns. What are you most worried about? This is often the unspoken fear, like, is this cancer or will I lose my job? And E for expectations. What were you hoping we could do for you today? Maybe it's a prescription, maybe a referral, maybe it's just wanting to feel heard and validated.
And if you just treat the symptom but you miss the concern,
The consultation has failed. The patient leaves feeling unheard, their anxiety is still there, and that gap is where complaints are born.
there's another mnemonic here which sort of ties the whole thing together. The listen mnemonic.
Yes, that's a good one for the whole consultation loop. Lead with an open question, identify IC, show empathy, test understanding, which we'll come back to, explain the plan, and note the key points. It's a nice little map.
So for the SJT, focusing on those high-yield actions, the first, next, last approach, what's the sequence?
The sequence is always structured. First, you invite the story, a broad, open question, explicitly exploring IC. So if they say, I have a headache, you ask, and what are you most worried that headache might be?
You go straight for the concern.
You go straight for the concern. Next, you listen with your body, that's A solaire, and you reflect back the feelings. When the patient expresses distress, fear, frustration, you use a tool like the MSRA mnemonic. Name, understand, respect, support, explore. This is where empathy becomes an observable action. You name the feeling. It sounds exhausting. You validate it. I can see why you feel that way. And then you explore.
And then last.
Last, you clarify and you check for understanding. And the gold standard for this, which the GMC loves, is using teachback. Just so I can be sure I've explained it clearly, could you tell me in your own words how you're going to use this new inhaler?
Or something like, to be sure we're on the same page, what are the two main things you'll look out for that mean you need to call us back?
Exactly. That teachback step is so often skipped when people are running late, but it's critical.
We have this analogy from our sources of active listening being like you're an audio technician. That teachback feels like the final quality check.
It is absolutely the final quality check. You, the doctor, you tune the microphone with your solar posture. You invite the speaker onto the stage with ICD. You're checking the sound levels and the quality with your NURSI reflections when they show emotion. And then at the end, you play back the recording, the summary, and the teachback to make sure it's accurate before you hit print on the management plan.
It shifts the responsibility, doesn't it? It moves it from I told them to I made sure they understood.
100%. It's a huge shift.
I often wonder, though, if candidates know they should do this, why do they still get it wrong in the exam? Why do they rush?
Because the SJT is designed to make you feel rushed. It simulates that clinic stress perfectly. Rushing is a natural human response to pressure, and the trap answers play on this. They'll offer you an option to interrupt early, to reassure before you understand, don't worry, you'll be fine, or to use jargon. The safest action, even when you're late, is to pause, acknowledge the worry, use one open question, summarize, and safety net with teachback. Rushing is unsafe, it invalidates consent, and it scores badly every time.
This leads us really nicely into the next point, which is a massive differentiator in the SJT.
Yeah.
The distinction between empathy and sympathy.
Yes. This is a critical professional line to draw. Sympathy is pity. It's feeling for someone, oh, poor you, or that sounds awful. And it often, weirdly, creates distance. It can even minimize their experience.
Whereas empathy.
Empathy is an action. It's about naming the emotion, validating it, and then moving immediately to a collaborative plan. It shows them, I have heard you, I accept your reality, and now I am on your side to work on this together.
But I'm going to challenge that a bit. If a patient is clearly panicking, isn't a quick, simple reassurance, you'll be fine, safer than trying to remember a 5-step mnemonic like NURSI?
It's a great challenge, and it's a very tempting thought. But that quick reassurance, you'll be fine, is often heard by the patient as stop worrying, which dismisses their very real fear. And if the news does turn out to be bad, you've completely destroyed your credibility. The action of empathy, using a tool like adherence, it only takes a moment longer, but it's so much more protective. If a patient says, I'm terrified this is cancer, the best response isn't, don't worry. It's, I can hear how terrified you are. That is a completely understandable fear. You validate it. Let's look at what we know so far and figure out the next step together. You collaborate.
That action-oriented response is what gets the marks.
It's what gets the marks. We use the NEVER mnemonic to guide this. Notice the distress. Empathic, name-label the feeling. It sounds overwhelming. Validate it. I can see why you feel that way. Explore with an open question. And respond with a plan.
And there's another one here, feel plan, which helps sort of integrate that.
Exactly. Feel, name it. Empathize. Validate, explore, listen. Then you pivot. Plan options, land a decision, agree a safety net, and note it down. You contain the emotion, then you get back to the task.
So the common SJT pattern here is emotional distress. A patient is tearful or silent or anxious. The best action is always to acknowledge the feeling first.
First. Always first. And you have to avoid those trap phrases like, I know exactly how you feel because you don't, or don't worry, it'll be fine because you can't promise that.
So let's go back to that opening scenario, the tearful patient fearing cancer. The model phrase we should be reaching for is something like, it sounds overwhelming and frightening to be sitting with that fear. Thank you for telling me. Let's look at your notes and work out the next step together.
Perfect. It validates, it maintains professional boundaries, and it moves immediately to a collaborative action. That is a top-scoring response.
Okay, let's move into our second theme. This is where the stakes get even higher, high-stakes delivery. We're talking about breaking bad news and navigating language barriers.
Yes. When the stakes are at their highest, your communication has to be at its most precise and structured. In these moments, clarity and structure aren't just, helpful. They are paramount for safety, for dignity, and for patient autonomy.
Let's start with breaking bad news. When the news itself is difficult, the structure acts like a professional shield, doesn't it? It protects the patient from shock, and it protects the doctor from being overwhelmed. And this is where the spikes protocol comes in.
It is the global standard, and for good reason. The GMC is explicit that communication has to be honest, clear, and compassionate. Bad news needs preparation, and it needs follow-through. Spikes gives you that structure. Without it, doctors often just blurt out the news or completely fail to handle the emotional fallout.
Okay, so let's walk through the spikes framework step by step. Let's focus on the bits the SJT really tests.
Right. So number one is S for setting. This is all about preparation. It's the logistics. Find a private room, make sure there are tissues, sit down. Sitting implies time and equality. Standing implies you're about to run out the door.
And check who the patient wants with them.
Crucially, with their permission. And allocate enough time. The SJT will always score you down for telling bad news in a busy corridor or over the phone unexpectedly, or standing at the end of a bed in a 4-bed bay.
So that's setting. Then P, perception.
Perception. Before you say anything, you ask, what do you understand so far about your tests? Or what are you expecting the news to be today? This gives you their baseline, it lets you correct any wrong assumptions, and it helps you tailor the language you're about to use.
Then is invitation.
Yes. You hand control back to the patient. How much detail would you like me to go into today? Or would you like me to tell you everything? Or should we go step by step? You have to respect it if they say they want less detail or if they want someone else to hear it first. That's respecting autonomy in action.
Okay, now for the hard part. K for knowledge. The delivery.
This has 3 critical parts. First, the warning shot. I'm afraid I have some difficult news to share, or the news isn't what we had hoped for. Second, you give the core message in plain English. Avoid jargon, avoid euphemisms like, we've found a shadow, or the tumor is unhappy. Just be clear.
And the third part.
The third, and maybe the most important part, is you pause. You say the words, and then you are silent. You let it land.
And that silence leads straight into E for empathy.
Exactly. Because an emotion will arise in that silence, and your job is to respond to it. This is where you bring in your NURSI skills again. Name the feeling. Validate it. I am so sorry. This must feel devastating. What you don't do is jump straight to treatment options or survival statistics.
You stay with the emotion.
You stay with the emotion, you offer comfort, pass the tissues, ask if they want a relative called now. This step is about not abandoning them in their distress.
And finally, S for strategy and summary.
Yes. Once the initial shock has passed a little, you outline the immediate next steps. Not the plan for the next 6 months, just what happens next. Who will they see next? Who can they call? You check their understanding again with teachback, and you make sure they are not leaving with this awful news and no support.
That pause at the knowledge step and the response at the empathy step, they feel like the points of greatest vulnerability. Why do so many people get that wrong and jump straight from K to S, from knowledge to strategy?
Because treating the emotion is often harder than treating the disease. Doctors are trained as problem solvers. We see a problem, bad news, and our instinct is to start solving it with a treatment plan.
Right.
But if you launch into the treatment plan while the patient is still reeling from the shock, they will not hear a single word you say, and any consent you get later will be invalid. The empathy step buys you credibility, and it allows the patient's brain to catch up with the news before you start planning.
To help with that follow-through, there's another mnemonic here. Warm plan.
Yes, warm plan is good for the post-delivery phase. Warn, ask understanding, respond to emotion, make a plan. Then paperwork, link to the team like the specialist nurse arrange follow-up, and next steps agreed. It's a good checklist to make sure you don't forget the practical support.
So in an SJT, the top-ranking option has to include finding a private space, checking PI, using that warning shot, stating the news plainly, pausing, and then detailing a concrete, immediate plan.
That's the one.
Okay, let's talk about the other high-stakes area, language barriers.
Right. And if we're talking about systemic risk, very few things compromise patient safety as quickly and as completely as a communication breakdown because of a language barrier. It's a fundamental safety risk. It affects everything: consent, history-taking, autonomy. This is non-negotiable in the SJT.
The sources are absolutely crystal clear on this. Using a professional interpreter is the only acceptable standard. But let's get into the why. Why is using family or friends, or especially children, such a massive red flag?
It's a triple threat. First is accuracy. A layperson, especially family, they're not medically trained. They can misunderstand complex terms, or worse, they might deliberately edit or omit information they think is too distressing. So we're not getting a true history or valid consent.
Right, and the second?
Second is confidentiality and safeguarding. Using a child is a clear safeguarding failure. They should never be put in that position. Third is autonomy. If a family member is translating, the power dynamic is all wrong. They can, even unwittingly, coerce the patient into a decision they don't really want.
So the GMC says you have to take all reasonable steps.
Yep.
And the high-scoring SJT answer is always.
Arrange a professional interpreter. Phone, video, in person, it doesn't matter as long as they are a professional.
Okay, so let's detail that process, because the SJT often tests this as a sequence of steps. The interpret mnemonic seems useful here.
It's a good way to structure it. Interpreter first. Needs, check if they need BSL or other accessible information. Teach back to check understanding. Explain plainly in short sentences. Record the details, the interpreter's ID, the language, privacy. Remote if it's urgent phone or video. Encrypted and secure channels. And translated leaflets if they're available.
But the real nuance, the thing that separates the good answers from the best answers, is often in the process of actually using the interpreter, isn't it? Briefing them, managing the flow.
Exactly. That's the depth you need. You have to brief the interpreter before you start talking to the patient. You set the scene. We're going to be discussing a new diagnosis of diabetes, and I'll need to explain insulin injections. You set the ground rules. The cardinal rule is the triangle. You, the doctor, should be looking at and speaking directly to the patient, not the interpreter. You say a short sentence, you pause, you let the interpreter translate, and then you wait for the patient's reply.
So you're maintaining that doctor-patient relationship, and the interpreter is just the channel.
Precisely. It allows you to watch the patient's nonverbal cues and maintain control of the consultation.
So the high-yield sequence for the SJT is: Step 1, always arrange a professional interpreter. Step 2, brief them. Step 3, manage the triangle. Step 4, use short sentences. Step 5, use teach back before any final decision is made.
And the trap answer is always the easy way out. Use the teenager to translate. That will score worst. Or proceed without checking understanding. Any consent you get then is invalid. Patient safety and autonomy always, always trump convenience.
Okay, theme 3. This is when things get heated. Managing agitation and risk. The patient or relative is angry, frustrated, maybe verbally aggressive. And the first step, as we keep saying, is counterintuitive. It's to slow down.
You slow down to engage the structure. De-escalation isn't just about being nice. It's a safety-led communication behavior. The SJT is testing whether you prioritize physical safety first, then maintain nonverbal control, and then set clear, fair professional boundaries. You can't solve the clinical problem if you don't feel safe.
What does safety first actually look like in a clinic room with an angry patient? What are the practical steps?
It's about immediate situational awareness. First, you make the environment safe. Scan the room. Is there anything that could be used as a weapon? Are you between them and the door? You need to keep a physical distance, at least 2 arms lengths, and maintain a clear exit route for yourself. And, crucially, invite a colleague or a chaperone in early. If you feel threatened, safety in numbers beats turning to be a hero.
And your own nonverbals.
Yes, your nonverbal control. A relaxed, non-challenging stance, hands visible, not on your hips, not pointing, and never, ever match their volume. If they shout, you speak softer, slower. A low, slow, neutral voice. Matching volume just pours fuel on the fire.
So once safety is secured, you apply the structure, the calmer mnemonic.
Yes. This is the stepwise approach to diffuse the tension without getting into an argument about who's right or wrong. So C is for calm, stance, and tone, which we've just covered.
Then A is for acknowledge feelings.
Right. You're not agreeing with them, you're just acknowledging their emotion. I can see how frustrating this delay must be for you, or I can hear that you feel you haven't been listened to.
L is for listen and allow venting.
Let them get it out for a short, controlled period. Don't interrupt unless they're being abusive, just let them map out the problem for you. Then M is for map the issue. Clarify what the actual problem is, what happened, and what matters to them right now.
And then it gets firmer. E is for explain limits.
This is where you set the boundary, neutrally but firmly. I want to help you, and I can do that if we can both speak calmly. We have a zero-tolerance policy for personal abuse here, and then R is for resolve with choices. You offer them practical, immediate options to give them back a sense of control.
So something like, we can continue this conversation here, or we can move to a quiet room with my colleague present.
Exactly. Or I can arrange for you to speak to the practice manager, or I can try and find a solution for you right now. You're giving them agency.
The power of that calmer model seems to be that it validates the person by acknowledging and listening, but it firmly manages the behavior by explaining limits and offering choices. It stops you getting dragged into a fight.
100%. The patient feels heard, which often diffuses half the anger straight away, but you stay in professional control. And if they cross that line you've set, if they continue to shout or become intimidating, then you terminate the consultation safely. You explain what's happening, you involve senior staff or security, and you always, always document it.
That brings up a good point. How do junior doctors manage that pressure to maintain a calm stance when they might, genuinely feel threatened inside?
And that is where the escalation and colleague involvement piece is so critical. And it's highly tested in the SJT. Calling a colleague is not a sign of weakness. It is a sign of safety awareness and professionalism. It gives you physical backup, and it gives you a witness. The SJT will always score an option that secures safety and gets a witness early very highly.
Which leads us to documentation and reporting.
Non-negotiable. After any incident like this, you have to write a factual note. Not, the patient was aggressive, but the patient raised their voice and swore twice. You detail the behavior you observed, the risks, the actions you took with Calmer, who was there, and the final plan. And then you must follow your local incident reporting route, like DATIX. This is vital for system improvement and for making sure staff get support and a debrief.
So the trap answers are all the reactive ones. Shouting back, making promises you can't keep, like, I'll get you seen in 5 minutes.
Yes, because that just rewards the behavior. And the biggest trap of all is ignoring your own safety cues and staying alone in a room when you feel unsafe. That is a massive risk. The top scoring action is always secure backup and distance first, then use Calmer.
Okay, our final theme. Confidentiality and collaboration, especially with relatives and carers. This feels like connecting everything back to the bigger picture of clinical partnership.
It is. Involving families is essential for safe care, especially around things like discharge planning. But it has to be done with the patient right at the center. Confidentiality is the default rule. You can't just set it aside for convenience or because a relative seems nice.
And that's a really complex balance, isn't it? Especially when the relative is distressed or demanding, like in our very first scenario. The GMC says we have to respect autonomy, which means the patient's wishes are what guide information sharing.
Precisely. You only share the minimum necessary information, and you do it via secure channels. The moment you breach confidentiality by talking about results in a corridor or sending detailed notes to a personal email, you've broken that trust. This is where the carer mnemonic gives us a structure.
Okay, let's break down care.
So C is for consent and preferences. You establish what the patient wants shared, who, what, and how. A is for assess capacity. If you have any doubt at all that the patient can make this decision, maybe they're delirious, confused, very depressed, you have to do a formal Mental Capacity Act assessment. R is for relevant minimum share, only what's strictly necessary. E is for engage carers, either with permission or through the best interests process if the patient lacks capacity. And the final R is for record decisions. Document everything: who, what, why, and how.
So the top scoring action always starts with that first C,
Yeah.
consent. If the patient has capacity, you just ask them, who would you like us to involve and what are you happy for us to share?
Yes. But the real SJT challenge, the thing they love to test, is when the patient's capacity is fluctuating or clearly absent due to an acute illness, for example, or a cognitive decline. And that is when the Mental Capacity Act 2005 kicks in. And it's legally binding.
Okay, let's spend a bit of time on the MCA because this is a critical medical legal area. What's the fundamental principle? What's the two-stage test?
The MCA has 5 core principles, but the first one is the most important for the SJT. You must assume capacity. You start from the position that the patient can make the decision. If you have a reason to doubt that, then and only then do you apply the 2-stage functional test of capacity. And it's for that specific decision at that specific time.
So stage 1.
Stage 1 is, does the person have an impairment of their mind or brain? That could be delirium, a stroke, severe pain, the effect of a drug. If yes, you go to stage 2. If no, they have capacity, end of story.
And stage 2?
Stage 2 asks, is that impairment causing an inability to make the specific decision? And to lack capacity, they have to be unable to do just one of the following 4 things. 1, to understand the relevant information. 2, to retain it long enough to make the decision. 3, to use or weigh that information as part of the process. Or 4, to communicate their decision by any means at all.
So if they fail on any one of those 4 points in stage 2, they lack capacity for that decision. And this is where involving the family becomes a legally guided process.
Exactly. If the patient lacks capacity, the doctor must act in the patient's best interests. This means you have a duty to involve people close to the patient, relatives, carers, to try and work out what the patient's past wishes and values were. You have to weigh the risks, like a loss of privacy, against the benefits, like a safer discharge. And crucially, the SJT will expect you to choose the least restrictive option and to document your reasoning for the best interests decision.
So if we loop all the way back to our opening scenario, the distressed relative demanding scan results. Even though the patient is tearful, we still assume capacity until proven otherwise.
Correct. If that tearful patient, despite being scared, says to you, I don't want my relative to know anything until I've had a chance to process this, then that autonomy must be respected. Your action is to politely decline the relative's request, explain that you have to speak to the patient first, and offer to talk to the relative later about general non-confidential support. You always go back to see consent and capacity first.
And the trap answers are pretty clear then. Never discuss everything with relatives by default, never email notes to a personal account, and never, ever skip the capacity assessment and decide on your own. That's unlawful.
The rules are patient wishes first, minimum necessary sharing documented clearly, and always follow the MCA when you're in doubt.
Okay. We have covered a huge amount of ground: active listening, empathy, spikes for bad news, language barriers, calmer for agitation, and the legal side of confidentiality and capacity. It's all tied together by this need for structured, GMC-compliant communication. Let's do a quick mini rapid-fire recap of those key SJT decision patterns, just focusing on that immediate best step.
Yeah, being able to recall the framework and that correct first step under pressure is what gets you the marks.
Okay. A patient is tearful about their pain and they're scared it's cancer. What's the first thing you do?
Acknowledge the feeling using NURSI. That sounds frightening. Then use ICE to find the real concern. Reflect it back. Then, and only then, pivot to planning the next steps together.
A relative is shouting about delays in the waiting room in front of everyone.
Ugh, position yourself safely. Distance. Exit. Invite a colleague over. Acknowledge their frustration using calmer. Set your limits calmly. Offer them a choice, like moving to a quiet room. And make sure you document and incident report it afterwards.
Urgent consent is needed. The patient speaks very little English. Their 15-year-old child offers to translate.
You politely explain why using a child is inappropriate and unsafe. You arrange for a professional telephone or video interpreter immediately. You use teachback before you take consent, and you document all the interpreter's details.
You're delivering a new diagnosis of cancer. At the empathy step of spikes, the patient just bursts into uncontrollable tears.
You stop talking about the plan. You allow the silence. You validate that intense emotion. Take all the time you need. This is shocking news. You offer support tissues, water, a moment alone. You do not move on to strategy until they give you a cue that they are ready.
A care home manager calls for a detailed update on a resident who is drowsy and confused, and so lacks capacity for that decision.
You trigger the MCA best interests pathway. You share only the relevant minimum information that the care home needs to provide safe care. You document your best interests reasoning, and you consult with the care home and any known next of kin. You do not share the entire medical history. These are the moments. These are the moments where these structures become your professional armor. They keep you compliant, compassionate, and they keep you safe.
Let's try and consolidate this entire deep dive into 3 one-line bullets for revision. What are the key takeaways?
Okay, 1. Always prioritize structure, safety, and empathy using tools like spikes, calmer, care over your own feeling of being rushed or uncomfortable. 2. Understanding must always precede action. Use active listening tools like I see and reflection, and always use teachback to ensure you have shared understanding and valid consent. Never assume they've understood you. And 3. When risk is present, be it anger, a communication barrier, a doubt about capacity, you escalate early. Get a colleague, a senior, a professional interpreter, and understand the legal frameworks like the MCA, and make sure everything is documented and incident reported thoroughly.
That is a phenomenal, really deep analysis of the communication knowledge needed for the MSRA SJT. Thank you so much for guiding us through all of those frameworks and the medico-legal details.
It's my pleasure. And just remember, these frameworks aren't just abstract exam theory. They are genuinely the safest and most effective way to practice medicine in the NHS. They protect you, and they protect your patients. For anyone wanting to do more prep, we'd strongly encourage you to look at the resources and courses at PASMSRA.com.
Mastering the conversation really is mastering the consulting room. You have the structural tools now. Use them to communicate clearly, kindly, and safely. We'll see you next time on The Deep Dive.